Neoplastic and non-neoplastic space-occupying lesions produce a variety of clinical deficits. In general, deficits arise either from direct or indirect disruption or destruction of nervous system parenchyma. Direct tissue injury may affect brain, spinal cord, cranial nerves, or nerve roots. Indirect tissue injury may result from a mass in the meninges or other soft tissue that secondarily compresses nervous system structures, or from hydrocephalus due to the obstruction of the flow of cerebrospinal fluid. In addition, the presence of an intracranial mass increases the likelihood of epileptic seizures, particularly if the mass lies near the cerebral cortex. As with most neoplastic tumors, clinical deficits resulting from non-neoplastic tumor-like lesions most often become conspicuous over a subacute time frame, typically days to weeks, as a result of the accumulation of inflammation and vasogenic edema and their effects on surrounding tissue. Without treatment, deficits generally progress in severity. Anatomic localization of the lesion is deduced from the aggregate pattern of neurological deficits and consideration of the direct and indirect effects of the mass. It is possible, and likely in some cases, that a multiplicity of lesions is present. When a tumor-like lesion of the nervous system is suspected clinically, imaging should be performed with the primary goal of identifying the lesion that is producing symptoms and the secondary goal of differentiating neoplastic from non-neoplastic etiologies. The neurological complications of sarcoidosis, tuberculosis, and tumefactive demyelination can mimic neoplastic disease of the brain and spinal cord. Although these diseases share clinical, radiographic, and pathologic features with nervous system tumors, they are most often treated non-surgically. Nervous system manifestations occur in approximately 5% of patients with sarcoidosis and include meningitis, cranial neuropathies, visual loss, hypothalamic and pituitary dysfunction, myelopathy, peripheral neuropathy, myopathy, and hydrocephalus. Nervous system manifestations occur in approximately 10% of patients with tuberculosis via hematogenous dissemination and intraparenchymal tubercle formation and rupture, producing cranial neuropathies, hypothalamic and pituitary dysfunction, myelopathy, peripheral neuropathy, and hydrocephalus. Tumefactive lesions occur in 1 to 2% of patients with multiple sclerosis. Cerebral lesions behave like tumors and most often produce sensory motor or cognitive deficits. Tumefactive lesions of the spinal cord in neuromyelitis optica can produce weakness, sensory loss, and autonomic dysfunction caudal to the lesion. Sarcoidosis is an idiopathic, non-infectious inflammatory disease with non-caseating granuloma formation, most often involving lung interstitium and hilar lymph nodes. The clinical course of sarcoidosis can be either monophasic or relapsing. In the imaging examples shown here, panels A through C show images from a 31-year-old man who presented with several weeks of headache and nausea. Panel A is an axial T2 flare image showing abnormal hyperintensity in and surrounding the midbrain. Panel B is a T1 post-contrast scan showing both nodular and smooth leptomeningeal and parenchymal enhancement encasing the brainstem, suprasellar cistern, and inferior frontal sulci. Panel C is a sagittal post-contrast image showing the same. In images D through F of a 62-year-old woman who presented with double vision, headache, and right eye pain, we see abnormal contrast enhancement of the trigeminal nerves in panel D, of the oculomotor nerves in panel E, and of the extraocular muscles and lacrimal gland within the right orbit in panel F. Tuberculosis is an infectious disease transmitted by inhalation of aerosolized droplets containing Mycobacterium, with caseating granuloma formation occurring most often in lung alveoli. Tuberculosis is more common among immunocompromised patients, and symptoms will progress without antibiotics. In the imaging examples shown on this slide, panels A and B are from a 61-year-old woman from Cameroon with reactivated pulmonary tuberculosis who presented with subacute progressive headache, somnolence, and meningismus. The images show abnormal, diffuse, smooth leptomeningeal enhancement, as well as multiple small intraparenchymal lesions, including a left parietal lobe lesion in panel A and a left cerebral peduncle lesion in panel B. The images shown in panels C and D are from a 19-year-old man from China with reactivated pulmonary tuberculosis who presented with subacute progressive headache, meningismus, and fever. Multiple clustered rim-enhancing lesions are seen throughout the basal meninges and in the sylvian fissures. These lesions show restricted diffusion internally, as noted on the diffusion-weighted image shown in panel D. There is also ventriculomegaly due to obstructive hydrocephalus. Panels E and F are from a 43-year-old woman from the Dominican Republic who presented with subacute progressive headache and left hemiparesis and was found to have a solitary right intrapontine mass. The lesion has a rim of abnormal T2 hyperintensity that extends into adjacent parenchyma and a thick, relatively uniform rim of enhancement surrounding the lesion in the pons. Multiple sclerosis is an idiopathic, non-infectious inflammatory disease producing well-demarcated lesions predominantly in the white matter with axonal demyelination, reactive astrocytosis, microglial activation, and a surrounding perivascular lymphocytic infiltrate. Tumefactive lesions occur in 1 to 2% of patients with multiple sclerosis. The images on this slide are from a 29-year-old woman who presented with subacute progressive right-sided hemiparesis and dysphasia. She had no history of prior neurological symptoms. A large T2 hyperintense lesion centered within the left periventricular cerebral white matter exerts mass effect on surrounding structures. The lesion shows patchy internal enhancement and an incomplete rim of irregular peripheral enhancement. Perfusion imaging, shown in panel D, shows no elevation of cerebral blood volume associated with the left hemispheric lesion. A small non-enhancing T2 hyperintense lesion, distinct from the left hemisphere lesion, is visible in the right periventricular white matter. The patient's age and sex, as well as the presence of non-acute and acute periventricular lesions, made the diagnosis of multiple sclerosis most likely. Neuromyelitis optica is characterized by longitudinally extensive expansile central spinal cord lesions associated with an antibody to either aquaporin-4 or myelin oligodendrocyte glycoprotein, or MOG, both producing extensive demyelination with axonal damage, necrosis, and loss of oligodendrocytes in both white and gray matter. In the images below, a 37-year-old woman with a history of optic neuritis presented with subacute progressive paraparesis, band-like back and torso pain, leg paresthesias, and urinary incontinence. A longitudinally extensive expansile T2 hyperintense lesion of the spinal cord is shown, with abnormal enhancement throughout the lesion. The T2 signal abnormality involves the gray and white matter of the spinal cord. Serum testing for the neuromyelitis optica immunoglobulin G antibody was positive. In all of these examples, it is clear that non-neoplastic tumor-like lesions of the CNS and surrounding tissues present a diagnostic challenge to the neurosurgeon. These lesions share clinical, radiographic, and pathologic features with CNS tumors, but are most often treated non-surgically. The epidemiology, clinical features, diagnostic approach, radiographic findings, natural history, and treatment of each disease is discussed in this chapter. Attention to symptomatology, including non-neurologic findings, can help prevent misdiagnosis and delay of proper treatment.